Nutrition and Hydration in the Newborn by Merab Nyishime and Assumpta Kayinamura Mwali. Introduction.
Hello, I'm Merab Nyishime, working for Partners in Health, and I'm a nurse by professional. Today, we learn the course related to fluid, electrolyte, and nutrition.
Overview.
By the end of this chapter, participants will be able to understand the importance of nutrition and weight gain for neonatal survival and brain development, feeding as an essential medication. Identify methods to assist mothers in breastfeeding and increasing milk supply. Describe the key element of IV fluid therapy in newborn. Calculate daily feeding advancement according to the age and birth weight. Recognize and manage feeding intolerance and necrotizing enterocolitis. Understand how to prevent and treat hypoglycemia in the newborn. In this chapter, we cover infant feeding guidelines, both for well and sick newborn, feeding intolerance and necrotizing enterocolitis, and hypoglycemia. Feeding guidelines will be reviewed first, and we will explore the differences between the guidelines for well and sick newborn. Well newborn are those with a stable respiratory and the cardiac status, and a birth weight of over 1,500 grams. Sick newborns include those who are unstable or very low birth weight. Breastfeeding is the recommended feeding mechanism for well newborns. Well newborn can be breastfed on demand, and breastfeeding provides all nutrients needed for growth. Breastfeeding should occur at least 8 times per day, every 2 to 3 hours throughout the day and night. Both breasts should be offered at each feeding, alternating which breast is offered first. Artificial milk should be reserved to supplement when mother's milk supply is inadequate. Breast milk is produced on a supply and demand basis, meaning that milk must be removed from the breast in order for more milk to be formed. Mothers of newborn who cannot breastfeed due to illness, prematurity, or any other reason should be advised to begin expressing breast milk early and often, at least every 3 hours a day and night, to encourage milk supply and avoid breast engorgement. Sometimes mothers will have difficulty with breast milk supply. In these cases, there are several methods they can employ to increase supply. Mothers should get plenty of rest and stay hydrated, drinking 6 to 8 glasses of water, fruit juice, and or milk daily. They can also increase protein intake by eating more daily, eggs, peanut butter, meats, and nuts, and should be sure to breastfeed 8 or more times per day for at least 20 to 30 minutes. Newborn should be fed from both breasts at each feeding. If the newborn is full after one breast, the mother can hand express milk from the other breast to stimulate milk supply. She should assure good position and latch of the newborn onto the breast. The 4 main complications of breastfeeding that we review are sore nipples, breast engorgement, blocked milk ducts, and mastitis. While breastfeeding should not be painful, many mothers have mild nipple tenderness during the first week when their newborns first begin to suckle. To treat sore nipples, mothers should assure good lash and develop repeated pressure to the same area of the nipple. They should breastfeed on the less painful side first. After feeding, the mother can rub breast milk onto the nipple and let them air dry. Topical moisturizer can be applied to nipple to help healing, but should be wiped off before the next feeding. Consider topical antibiotics for infection if nipples are sore, cracked, red, and irritated, crusted, or if there is no improvement in pain within 2 to 3 days. Breast engorgement is caused by swelling of the breast from buildup of breast milk due to missed feeding or inadequate milk removal. Symptoms include breast erythema and firmness, tenderness, and flattened nipples. To treat breast engorgement, apply cold cloths to breast between feedings and gently massage breast before and during feeding. Mothers should hand express milk remaining in the breasts after feeding or if feeding is missed. If the newborn cannot latch on due to flattened nipples, hand express to soften area around nipples. Mothers should breastfeed or hand express at least every 2 hours until engorgement improves. Blocked milk ducts occur when a milk duct is not draining well, causing pressure to build up behind the block and cause swelling. These will appear as a hard reddish lump that feels like a pebble in the breast, and the mother will experience tenderness in the area. The mother should be well, except for the blocked duct, with no fevers, chills, or other signs of infection. She should continue breastfeeding and use warm, moist cloths on the breasts before and during feedings. Mothers should breastfeed on the blocked side every 2 to 3 hours and change the position used to breastfeed so that the infant's chin points toward the block. Mothers should try to massage the block with downward motion toward the nipple while breastfeeding, and the block should improve within 24 to 48 hours. Mastitis is a hot, painful, and swollen breast in mothers with systemic signs of illness due to inflammation and possible infection of milk ducts. It usually occurs in only one breast at a time and can be caused by an untreated blocked milk duct, skipped feedings, cracked nipples, stress, and inadequate rest. Mastitis presents as redness of the breast or streaks that feel hard to the touch. The breast will be hot to the touch, swollen, or painful, and the mother may experience aches, chills, nausea, and fever. To treat mastitis, the mother should continue to breastfeed and be reassured that it is safe for the newborn. If breastfeeding is too painful, she can hand express milk and resume breastfeeding as soon as she is able. She can apply warm, moist cloths to the breast before and during feeding and should drain breast every 2 to 3 hours, either by breastfeeding or hand expressing. Mothers should be sure to maintain good hydration and nutrition and should be given paracetamol for fever or pain. Give mothers antibiotics if fever or symptoms persist for more than 12 to 24 hours. Thank you so much.
I'm Assumpta Kayinamura Mwali. I'm a member of Rwandan Pediatric Association. I want to talk about food and nutrition for babies. Next, we'll look at feeding guidelines for sick newborn. To review, well newborn are those with stable cardiorespiratory status and who weigh more than 1,500 grams, while sick newborn are those who are unstable or low birth weight. Premature and low birth weight infants need a great deal of fluid and nutritional support. The smaller and more preterm the newborn, the more fluid and calorie are needed per kilogram. Sick newborn requiring feeding support are provided fluid and medication based on their weight. Birth weight is used as the weight for calculation until the newborn's current weight exceeds the birth weight, after which point current weight is used. The protocol has two different charts to determine the volume of IV and enteral fluid that infants should receive. These charts show how to start and advance fluid for infant according to their weight, with all of the volume pre-calculated for convenience and accuracy. These charts can be used when an infant can start advancing from trophic to higher volume enteral feed on day of life 1 and advance without difficulty to full feed. However, sometimes an infant does not tolerate the feed, or mother cannot provide adequate breast milk for the feeding advancement, and therefore they must be delayed. In this case, refer to this chart for total daily fluids and enteral advancement when the day of advancement is not tied to the day of life. These charts require calculation to be individualized for each patient. We will practice using both types of chart in this chapter. Unstable newborns should initially be NPO and be given IV fluid. They may receive trophic feed, as we will discuss soon. This is the table we use to determine how much IV fluid to give to sick newborn. Let's practice. Francis was born weighing 1,400 grams and had pneumonia. He is now day of life 2 and weighed 1,300 grams. He still has too much respiratory distress to be enterally fed. What is the total volume of IV fluid that he should be given per day? On day of life 2, he should get 120 milliliters per kilogram per day. Using his birth weight of 1.4 kilo gives him 168 milliliters per day or 7 milliliters per hour. Because newborn have a high energy demand, they should always be started on G10 rather than G5. If a newborn is persistently hyperglycemic on G10, the volume of infusion should be minimized. If the blood sugar is still too high, change the newborn to G5 1,4 ringerlactate and monitor glucose closely. G5 1,4 ringerlactate should be used instead of G5 water because G5 water is hypotonic. The need to change from fluid made from G10 to G5% occurs most frequently in extremely low birth weight newborn who require a high volume of IV fluid. In the first 24 hours of life, newborn do not need supplemental electrolytes due to higher baseline total body sodium content and decreased renal function. After the 24 hours of life, newborns do require maintenance sodium of 3 milliequivalent per kilogram per day and potassium of 2 milliequivalent per kilo per day. Newborn usually gets these electrolytes through breast milk, so if feeding is established, newborn can remain on G10 as they advance off of IV fluids and are increasing enteral volume. If feeding is not established, newborn requiring IV fluids need electrolytes generally given as G10 1,4 ringerlactate. If there is a concern for hyperkalemia or alkalosis, though IV fluid should be G10 1,4 normal saline. Newborn should not receive high amount of sodium, meaning that a half normal saline should not be used for typical maintenance IV fluid. Newborns with increased fluid loss should receive higher total volume fluid. For example, those on phototherapy should be given an additional 20 milliliters per kilo per day of total fluids. Other reasons for increased fluid loss include fever, vomiting and diarrhea, or those receiving heats by a radiant warmer for longer than about 24 hours. If a requested IV fluid concentration is not available, different concentration of IV fluid can be made by combining premixed fluids. For example, if a doctor orders G10% but it is not available, G5% and G50% can be combined in the correct proportion to make G10%. When mixing IV fluid, you should always have a second nurse check to ensure accuracy. Recipes for making commonly used IV fluids can be found in the protocol appendix. Even if infants are too unstable to be advanced on an enteral feed, with the exception those with necrotizing enterocolitis or bowel obstruction, they can receive trophic feeding. Trophic feeding is the practice of providing low-volume expressed milk, 10 to 20 milliliter per kilo per day, typically 15 milliliter per kilo per day, given every 3 hours. Trophic feeds improve feeding tolerance and growth while decreasing sepsis and hospital length of stay. Unless they have neck or a bowel obstruction, all infants who are not being advanced on enteral feeds due to illness severity should be given trophic feed until they are ready for higher enteral volume. When newborns are stable, they can start advancing from trophic to higher volume enteral feed. It is critical to advance feeds as soon as it's safe to do so because nutrition is such a critical part of an infant's care. There are very few absolute contraindications to advancing enteral volume of feeding. These are severe respiratory distress, more than 80 breaths per minute for preterm, and more than 70 breaths per minute for term babies. Shock, unresponsiveness, bilious emesis, or other evidence of bowel obstruction, confirmed or strong suspicion of neck. Severe sepsis and severe HIE grade 3. There are additional relative contraindications to advancing enteral feeds which require consideration and judgment from the clinical team and careful monitoring during feeds. The relative contraindications are tachypnea for preterm more than 70 breaths per minute and for term more than 60 breaths per minute. Feeding intolerance, cardiorespiratory instability, convulsion. Hypothermia with a temperature of less than 35 degrees Celsius. Follow the feeding advancement protocol to determine how rapidly to advance enteral volume and wean IV fluid. Newborns who weigh less than 1.5 kilo usually have an immature sac reflex, so it is best to start with NG tube feeds. For newborns larger than 1.5 kilo with a mature sac reflex who demonstrate interest in feeding, start with the oral feeds and give any remaining volume that they could not take orally by NG tube. For infants with a temperature of less than 35 degrees Celsius, rewarm the infant before giving enteral feedings. If it takes longer than 3 hours to rewarm the infant, start maintenance IV fluid. NG feeding should always be given by gravity, not pushed through a syringe. The term total fluid refers to IV fluids plus enteral fluids. Unlike IV fluids, enteral fluids are not completely absorbed into the vascular space. As a result, newborns receiving enteral fluids need a higher fluid volume than those receiving IV fluids. Clinicians should follow the recommended IV and enteral feeding rates in the protocol appendix to increase the total fluids daily by increasing the enteral feeding rate and decreasing the IV fluid rate. This should only be done if the newborn tolerates the increase without vomiting or abdominal distension. Monitoring weight gain is important in newborn, as every day of no weight gain is a day of no brain growth, which has permanent long-term impact on the infant's future. Weight gain is the most critical treatment for newborn to survive and thrive. Breast milk carries approximately 20 kilocalories per 30 milliliter, though it can vary in calorie content throughout the feeding, with the hind milk, the milk at the end of breastfeeding, being the most calorically dense. Standard artificial milk or formula has also 20 kilocalories per 30 milliliter. Premature infant may require extra calorie compared to term infant due to the increased growth need and should therefore feed long enough to empty one breast to ensure that they obtain hind milk. The mother should then hand express from the other breast to maintain milk supply and prevent engorgement. Preterm infants undergo rapid brain growth, so adequate feeding is especially important. Once the newborn achieves full volume feeds of 165 to 180 milliliter per kilogram per day, assess weight gain, ideally daily, but at least 2 to 3 times per week. Adequate weight gain is considered to be 15 to 20 grams per kilo per day for preterm infant and 20 to 30 grams per day for term infant. If a newborn does not gain weight adequately, it is necessary to either increase the total enteral volume of milk, the calorie density of the milk, or both. To increase the total volume, give an additional 10 milliliter per kilo per day every other day as tolerated. Many newborns will tolerate 180 to 200 milliliter per kilo per day. To increase the caloric density of breast milk, add formula powder to the milk, increasing the density by 2 kilocalories per ounce, 0.06 kilocalorie per milliliter. If this is well tolerated but weight gain remains inadequate, continue to increase by 2 kilocalories per ounce to a maximum of 8 additional kilocalories per ounce, 0.27 kilocalorie per milliliter, with a formula powder and or oil per the protocol. In addition to these measures, make sure at least 8 feeds are being given per day, no skipped feeds. Whenever possible, use the calorie-rich hind milk. Observe the feeding to ensure they are being given properly. Treat sources of increased metabolic demand, such as hypothermia, increased work of breathing, or anemia, and ensure that the mother is eating, drinking, and resting. The choice between increasing volume or caloric density depends on availability of formula powder, newborn's tolerance, and clinician preference. Both can be increased alternately with a likely maximum caloric intake of 26 kilocalories per ounce at 170 and to 180 milliliters per kilogram per day, which should be sufficient for adequate growth of even extremely preterm infant. Recipes for enhanced calorie feeds can be found in the protocol appendix. Enhanced calorie feeds should be discontinued prior to discharge to ensure that the newborn can maintain adequate weight gain with only breast milk. Discontinue enhanced calorie feeds when methylxanthine stimulant is discontinued 3 days prior to discharge and monitor weight gain. Prior to discharge, newborn should be monitored while solely breastfed to ensure adequate weight gain. The next topics to be covered are feeding intolerance and necrotizing enterocolitis or NEC. Feeding intolerance is indicated by mild abdominal distension and vomiting. Necrotizing enterocolitis is primarily a problem of severely preterm infant and is very rare in late preterm or full-term infant. Signs and symptoms include bloody stool, marked abdominal distension, visible loops of bowel under the abdominal wall, and discoloration of the abdominal wall, especially if accompanied by sign of sepsis. For a newborn with feeding intolerance, depending on the degree of concern, halt feeding and start IV fluids, slow the advancement of feed, or consider smaller feed at increased frequency, such as every 2 hours. If necrotizing enterocolitis is suspected, look for air in the bowel wall of abdominal X-ray to confirm the diagnosis if available. Management of NEC includes bowel rest and antibiotic therapy. Stop all enteral feeding and leave MG tube open to air to vent the stomach. Start IV fluids G10% 1,4 ringolactate or G12.5% 1,4 ringolactate at 150 milliliter per kilogram per day. IV fluid recipes are in the protocol appendix. Monitor the need for higher IV fluid volume or normal saline boluses. Give broad-spectrum antibiotics, either ampicillin, gentamicin, and metronidazole, or cefotaxime and metronidazole for 7 to 14 days. For patients with NEC, provide medication for pain control as needed, such as paracetamol per rectum, morphine 0.0 to 0.05 milligram per kilo IV every 4 hours can also be used, but may cause hypotension and decrease bowel motility. After the recommended course, slowly reintroduce enteral feed. Watch closely for intolerance, malabsorption, and obstruction due to strictures.
Neonatal hypoglycemia is low blood sugar in the first few days after birth. Moderate hypoglycemia is defined as a blood glucose level of 25 to 45 milligram per deciliter or 1.4 to 2.5 millimole per liter. Severe hypoglycemia is less than 25 milligram per deciliter or 1.4 millimole per liter. Those at increased risk for hypoglycemia include premature and low birth weight newborns, newborns who are large for their gestational age, newborn of a diabetic mother. Hypoglycemia can be caused by hyperinsulinism, birth asphyxia, feeding difficulty, sepsis, respiratory distress, or hypothermia. Signs and symptoms of hypoglycemia include tremulousness, stupor, lethargy, hypotonia, hypothermia, irritability, poor feeding, respiratory depression, convulsions, and coma. To test an infant for hypoglycemia, monitor blood glucose levels by a blood test. You can obtain blood by heel prick. For non-pharmaceutical hypoglycemia, determine and treat the underlying cause. The full management protocol is available in the following chart. This is the protocol for moderate hypoglycemia. This is the protocol for severe hypoglycemia. Both can be found in the printed version of the Neonatal National Care Protocols. Here are the recipes for making the IV fluid recommended in the protocol from IV fluid that you will likely have in stock. These are tables that guide you through advancing enteral volume and weaning IV fluid for babies of various birth weight and ages. We will practice using these tables in the case studies. These are recommendations and recipes for increasing the calorie provided in milk.
Case studies.
We will now go over a case study on a newborn named Jean-Claude to review this material. He is 2 hours old and 29 weeks gestation age with a weight of 900 grams. Jean-Claude has mild respiratory distress and has been placed on 5 liters per minute via oxygen concentrator. His temperature is 36.5 degrees and he's in an incubator. What IV fluid and rate should Jean-Claude get today? Jean-Claude should receive total fluid of 8 milliliters per kilo per day. This can be given as 65 milliliters per kilo per day IV fluid or 3 milliliters per hour of G10%. In addition, he can receive 15 milliliters per kilo per day trophic feed of express breast milk divided into every 3 hourly feed of 2 milliliters by NG tube. The next day, Jean-Claude is doing well, receiving oxygen from the oxygen concentrator, and his exam and vital signs are stable. He was started on caffeine therapy. What should the plan be for Jean-Claude's fluid and nutrition today? Should enteral feeding be advanced? For day of life 1, total fluids should amount to 100 milliliters per kilo per day. Jean-Claude should receive G10% at 60 milliliters per kilo per day or 2 milliliters per hour for his weight. He should receive enteral feeds of 40 milliliters per kilo per day or 5 milliliters every 3 hours. If exam remain unchanged, what should Jean-Claude fluid and nutrition be on day of life 2? On day of life 2, his total fluid should amount to 120 milliliters per kilo per day with IV fluid of G10% at 2 milliliters per hour and enteral feeds of 8 milliliters every 3 hours. Jean-Claude is now on day of life 11. He has advanced well on his feeding and is now on full enteral feeds at 180 milliliters per kilo per day or 20 milliliters every 3 hours. His weight is 810 grams, which is 90 grams below his birth weight. For the past few days, he was gaining only 4 grams per kilo per day. What should be the next step to optimize Jean-Claude's nutrition and weight gain? Jean-Claude's breast milk volume should be increased as tolerated to 200 milliliters per kilo per day. Ensure that he has 8 feeds per day, that he is getting hind milk whenever possible, and that hypothermia and other causes of increased metabolic demand have been addressed. If he continues to gain weight inadequately after these measures have been taken, the caloric density of his milk should be increased by 2 kilocalories per ounce, as tolerated to a maximum of 28 kilocalories per ounce. Jean-Claude is now 40 days old. His weight is 1.5 kilo and his postmenstrual age is 34.5 per 7 weeks. He has been gaining weight well, 15 grams per kilo per day for the past week, breastfeeding 4 times per day and having the rest of his feed as NG feed or breast milk enhanced to 24 kilocalories per ounce. He is off CPAP and oxygen and has not had any apnea episodes since caffeine was discontinued. He is out of the incubator receiving continuous KMC. What should the plan be for Jean-Claude's nutrition? Jean-Claude should be transitioned to full breastfeeding with no added caloric density, and his weight gain should continue to be monitored. Once he has demonstrated good weight gain, 15 grams per kilo per day, breastfeeding on demand for 3 days, he is ready for discharge home with KMC. Jean-Claude should be scheduled for a follow-up visit 1 to 2 weeks after discharge. Amina, the subject of our next case study, is on day of life 1 and weight 1.2 kilo. She has respiratory distress with oxygen saturation only intermittently over 90% with 4 liters per minute nasocannula oxygen. She has been on G10% for the past day. What fluid should she get today? You should give her G10% 1,4-ringal lactate at 100 milliliters per kilo per day, which would be 120 milliliters per day for her. Infant with an unstable respiratory status should not be fed nutritive volume entirely, but can be fed trophic feeds of 15 milliliter per kilo per day. Because she has been NPO for over 24 hours, it is important to add electrolyte to the IV fluid. Therefore, it should be G10% 1,4 Ringer lactate. Our next case study concerns a newborn named Joseph. He is on day of life 1, weighs 3 kilo, and has a perinatal hypoxic ischemic brain injury and active seizures. Because of the seizures, the doctor wants to keep Joseph NPO. He orders Joseph to receive G10% at 60 milliliter per day, which the nurse hangs. Was this correct? No, Joseph should have been given 60 milliliter per kilo per day, which would be 180 milliliter per day. It is critical to distinguish between milliliters per day and milliliters per kilogram per day. Our next case is baby Richard, born weighing 1.3 kilo with severe respiratory distress and possible sepsis requiring CPAP and antibiotics for 1 week. What nutrition and hydration should be given? Because severe respiratory distress is an absolute contraindication to advancing enteral feeds, he should have received IV fluids and trophic feeds. Especially on day of life 0, he should have been given G10 at 80 milliliter per kilo per day, which is 104 milliliter per day or 4.3 milliliter per hours, along with trophic feeds of 15 milliliter per kilo per day, 20 milliliter per day, or 2.5 milliliter every 3 hours. On day of life 1, he should have been given G10 1,4 Ringer lactate at 100 milliliter per kilo per day. It means 130 milliliter per day or 5.4 milliliter per hour, with trophic feeds at 15 milliliter per kilo per day. On day of life 2, he should have been given G10 1,4 Ringer lactate at 120 milliliter per kilo per day. It means 156 milliliter per day, 6.5 milliliter per hour with trophic feed. By day of life 3, his respiratory distress is mild with respiratory rate of 74 and mild retraction. What fluid and nutrition should he receive today? Because he no longer has severe respiratory distress, his enteral feeding volume should be advanced. The need for CPAP is not a contraindication to advancing enteral feeds. IV glucose has very limited nutritional value. Babies need enteral nutrition to thrive. This is day 1 of feeding advancement and day of life 4, so he should get 180 milliliter per kilo per day of total fluids, of which 40 milliliter per kilo per day, 52 milliliter per day, 6.5 milliliter every 3 hours. Therefore, 140 milliliter per kilo per day is IV, G10%, 182 milliliter per day, 7.6 milliliter per hour. The next day, he should get 70 enterally and 110 IV, then 100 enteral and 80 IV, then 130 enteral and 50 IV, then 160 milliliter enteral, at which time the IV fluid can be discontinued, after which he should be assessed for adequate weight gain. In our final case study, Simon is on days of life 6, weight 1.4 kilo, and is advancing on enteral feeds. Upon physical exam, the baby is noted to have abdominal erythema, distension, and tenderness. What should you do now? You suspect necrotizing enterocolitis. Make NPO and start G10%, 1,4 Ringer lactate, at 150 milliliter per kilo per day, which is 210 milliliters per day for Simon. Consider broad-spectrum antibiotics too. Assess Simon with laboratory and radiologic testing and observe his clinical course. After 48 hours, commit to either feeding intolerance or necrotizing enterocolitis. If intolerance seems more likely, slowly reintroduce enteral feeding. If you still suspect necrotizing enterocolitis, provide 7 days of bowel rest and 7 to 14 days of broad-spectrum antibiotics.
Summary.
Having completed this chapter, you should now be able to describe the importance of nutrition and weight gain to neonatal survival and brain development. Feeding is an essential medication. Identify methods to assist mother in breastfeeding and increasing milk supply. Describe key elements of IV fluids therapy in newborns. Calculate daily feed advance according to age and birth weight. Recognize and manage feeding intolerance and NEC. Understand how to prevent and treat hypoglycemia in the newborn. The following are key points on fluid, electrolytes, and nutrition. Stable newborn with a birth weight more than 1.5 kg should be offered breastfeeding on demand. Breastfeeding complications should be monitored and managed. Unstable newborn and those who are preterm and low birth weight initially require IV fluids with a volume and composition according to the protocol. All newborn except those with neck or bowel obstruction can receive trophic feeds starting on the day of birth. When newborn are stable, they can start advancing on enteral feeds. Once on full volume enteral feeds, newborn should be assessed for weight gain. The milk volume should be increased and/or supplemental calories should be added to the milk of newborn who are not gaining weight adequately. Feeding intolerance, NEC, and hypoglycemia should be monitored and treated promptly. Thank you.
Please help us improve the content by providing us with some feedback.